Okay, let's go ahead and get started. Welcome to the Assembly Health Policy Committee meeting on Wednesday, November 21st. We're noticed from 12:30 to 1:30 today. Let's start by going ahead and identifying ourselves for the record. Let's actually start with the phone. Mr. Dunbar? Are you there?
Dunbar.
And then Andy?
Andy Jones, State of Alaska.
Alana Habib, State of Alaska.
Natasha Pineda, Health Department, Anchorage.
Suzanne LaFrance, Assembly.
Sandy Kearney, Representative Kearney, Assembly.
And we have,
Desiree Camacho, Assembly Budget Analyst.
and then let's go ahead around the room.
Deanne Betko, Health and Human Services.
Mike Schmorman, Health Department.
Matt Allen, 4As.
Pedro Davis, Forest.
Shannon Kuhn, Health Department.
Adam Lays, regular Joe.
Eugene Haber, represent myself, but when they say state of Alaska, what part of state of Alaska? It's unclear who they are.
State of Alaska, Department of Health and Social Services, Office of Substance Misuse and Addiction Prevention.
Great. Okay. Thank you. Thank you all for being here. I know it's kind of a tough day before Thanksgiving. Mr. Constant is on his way. We may be joined by another person on the phone. Just also wanted to mention to the folks, especially from DHHS and the state, thank you for what you do. Day before Thanksgiving, I feel very grateful myself for the work that you do. I know a lot of times folks who serve the public aren't always acknowledged or appreciated, and the work you do is really important in keeping people safe and healthy. So thank you for that and what you do. So last time, just a quick recap before we go through the agenda. For the record, Mr. Constant has joined us. Last time we talked about sexually transmitted infections and Alaska having the dubious honor of being number one in the U.S. for transmission rates, infection rates, with the numbers rising here and in the U.S. Syphilis is a big problem. Lack of access to education, stigma, opioid substance abuse misuse, tied to increases in high-risk behavior, lack of access to care, all factors in those rising numbers. And our local DHHS is active in education, testing, and treatment. We also started a conversation on toxic flame retardants and had a presentation from the Alaska Community Action on Toxics group by Sue Chan, and looked at a draft of an ordinance that would ban the class of chemicals called organohalogens. One follow-up item we have before we move forward with further discussion on that ordinance is to get an understanding of how pervasive products that contain these chemicals are in MOA, and how big a problem do we have, since some merchants are opting out of selling these products. So hopefully, and we have been joined by Mr. Dunbar in person. Everyone has an agenda, and our focus today is on substance abuse and misuse and treatment, and we will start with a briefing by Director Pineda on the assessment you've been working on, upcoming community conversation. And we don't have too many folks here today, so if any of you want to come up and sit at the table and just join the conversation, you're invited to do that. And if you and Andy and Alana want to have discussion through your parts, that's great too. So thank you, Director Pineda.
Thank you. So before I get into the presentation that we have to prepare to talk a little bit about the assessment that we're going through, I just wanted to follow up on a couple items from the last time we met. I wanted to let you guys know that the public health team and the child care licensing team are working together and moving forward what they would need to do, what the costs associated are, and what the language and public input process would need to be related to any adjustments to their code related to vaccinations. So they'll be able to come in December and provide you with just a basic update of what that timeline will look like. because it requires public input and a financial analysis and those things that obviously won't be ready in December, but they'll be ready to tell you what their plan is in December. I think we spoke about this a little bit before the meeting started, that our team in Deanne Fetco, Deputy Director Fetco, is here, and in December their team will be ready and prepared to come and discuss animal control issues. I think that that's been brought forward as something that wanted to be a discussed topic, so we can work with you. She's ready to work with you on what that might.
Pick a date for that meeting.
I don't know if a date's been selected yet.
It's the third Tuesday, it's the 19th.
Yeah, so we'll.
Wednesday.
Okay.
We just want to make sure you guys know that we're available, and when you guys set your date, let us know, and then our team can work with you guys to make sure we provide the right kind of information and discussion that you're looking for.
Okay. Will you be in town? Okay, so
That's perfect time.
December 19th. Okay.
Okay.
We will shoot for that date.
And then in January, we're still moving forward with the plan to talk about environmental health, what we do, what we don't do, what we what is been assigned to other areas within the municipality that may be relevant for some of the discussions around homelessness and other things, as well as just what our group does. And Deputy Director Fetco would be working with her team on that as well. We are prepared with a position on criminalizing disease transmission, and when there's an ordinance that comes forward to us, we'll be prepared to respond to that. So I just wanted to make sure that I let you guys know that. I know that's still a pending item, and I think that'll come out at another committee, but since it's asked every time I'm here, I wanted to let you guys know that we will have a position on that and prepared to deliver that at that time. Last time I spoke with you guys a little bit about the fact that the state had opened up their emergency operations center related to the psychiatric emergency, specifically related to API. And as a part of that, at my department level, I am opened up what's called a DOC, Department Operations Center, which just allows me to have my emergency preparedness team work on identifying any areas that might not be caught up in the state EOC that we think is relevant and important. So that includes communicating directly with service providers, shelter providers, all the different groups that are working every day to serve their populations, and seeing if the crisis at the state level related to behavioral health and their funding of and infrastructure related to the services available in our city are having an undue impact on shelter services, are impacting other programming and other things that are happening. So they're in the process of collecting that information, and that information is then shared with the state, because the state's not collecting some of that community level information that we think is critical for them to be considering as they work through their process. So that's ongoing. Since we met last, that was a new addition to what we're doing. And so that's my general update. Our teams are all continuing to do all the areas of work that we're supposed to be, and lots of good things happening with our teams, new people joining. So we're having fun over at the health department, I think, when we can. Or I'm trying to have fun.
And Mr. Constance?
Thank you. So you just mentioned this Department Operations Center. Are you aware of APD still transporting people and kind of having to hold them in their car?
Yeah, so we had them follow that trail down, because one of my questions was, is that how frequently is that happening? How do we track that? To what degree is it happening, and why is that happening? And they have spoken anecdotally, and I think that it does happen. I don't think it's happening when you have somebody in a psychiatric emergency, and this was 3 weeks old information. They'll take you to a hospital. They know that they're going to drop them off and they're going to walk right out, because they're going to continue to be in an acute situation, or the hospital can't take them, and so typically they're having them be in that position. But I think Chief Dahl could speak to it more, but they have spoken with our partners over there, and there is truth to that story, like that is happening. I received a call over the weekend of a shelter operator who had somebody in a violent psychiatric event inside a closed place. They had to push their panic button and needed help. And while they were waiting for help to come, called me to talk through what are their options. And we walked through, what I can do is I can document this, and I can make sure that the operations that are happening at the state level understand the magnitude of the impact of releases from API or other places on our service system.
So, quick follow-up to that then is, what has been your perception of the state's response? Now they have this operations center up, but it seems to me like a lot of window dressing. Is it substantive and is it creating any kind of impact?
I haven't received an IAP. I received one, and I think that they've closed down some of the branches, and so they've made progress. What that progress is exactly, I don't have insight into, but I'm sure that we can ask them to present to you guys an update on their progress. I think that we haven't, as a system, and I can't speak on behalf of the state, but I do know, like our team, we haven't opened up emergency operations related to behavioral health issues before. So working through what does that mean, we have a really great public health emergency model that could be applied to disasters of a physical nature. And so applying that to those new settings, I think, just takes some time to figure out what does that mean when we're talking about this new topic. So it was an opportunity for our team. I felt we could have done nothing, but there was clearly a need to capture that information and communicate it up, and also it gives us practice on who are the providers, who should we be asking, what are the kinds of questions you ask in this type of an emergency. And there are other states that have county systems that do this more frequently, so I think it's the first time. I could be wrong.
I think it's a culture of, I'll be honest, I'm not the incident commander for that event at this point, so I would say to speak any details would be, I couldn't do it justice, but what I can tell you is disaster response and incident management, probably just like at the muni level, it only goes so far sometimes, and so it's very new to a lot of these individuals. And it's a hard lesson that we are learning, that sometimes people, when you operate on a normal day-to-day basis versus incident command, is a different beast, right? And so it's very hard to push that system forward. That's the most I would say at this point, unless we want to bring in probably either Dr. Butler or Heidi Hedberg, who's the incident commander for that event.
Who could give you an update on it.
That would be important, because I'm not seeing any practical benefit to the community at this time of change. And if it's an emergency operation, then we should be seeing active change. Otherwise, it seems like it is maybe just more of pushing the ball forward and saying we're doing something while we're allowing the crisis to continue being managed in our streets.
Right.
I'll make sure that message goes back to Dr. Butler, and we'll get you.
And in the meantime, we're trying to be an open vessel to capture what does it look like on the street, what is happening, how is that impacting regular shelter operations. If you're supposed to run a shelter and you're not running behavioral health services, but you have most everyone is in behavioral health crisis, how does that affect whether you can shelter people or not?
Or zoos.
Right.
Or zoos, frankly.
So they're
Zoos. The zookeeper gets murdered because API doesn't lock up someone who should have been locked up.
So we're doing our best to capture that information with the resources that we have and put that together in a way that's meaningful and feed that up to the state as our partner. And that is what we're doing right now, as an update for you.
Thank you, Mr. Constant. Thank you, Ms. Pineda.
So I think most of you have in front of you some slides. I'm not going to be presenting any hard data today. I'll let our partners at the state provide that information. Most of you know, and I think maybe Sarah Richardson has been here in the past, but she's actually doing a key informant interview right now and couldn't be present. So I'm presenting this on her behalf. We would like to come back in March and be able to present our whole entire community needs assessment to you, and it should be currently that's our timeline for it to be completed. So as I said, Sarah Richardson is an urban fellow who I think we spoke about before. Sergeant Elijah Gutierrez is on loan to us from our partners at OSMAP. So Andy and they've been gracious enough to deploy him to our department, and they've been working very closely on conducting a community needs assessment, which includes many different things, as well as doing lots of training and drug disposal bag deployment around the city. And they're just doing a lot of really great work. And in March, we'll be able to do a complete overview of their volume of effort and the data that they've identified. So the community needs assessment that they're completing includes these 3 areas. There's a comprehensive literature review of best practices and policies related to substance use and alcohol. And then there'll be a policy comparison about what's happening at the state level and what's happening in Anchorage and what are our gaps and needs and what should we be doing, what there may be some assessment of things that have been being done that aren't effective, and so they'll be able to bring that forward. It's pretty comprehensive. I feel like it's a voluminous literature review in draft form, it's very large and in depth, so we're looking forward to that being finalized. They're also doing quantitative data collection specific to Anchorage, so they've been working with our partners at the state to get Anchorage-specific data, but also they've been conducting surveys at different locations related to different things that they're finding are important. So they recently conducted a I think over 50 participants at a 4A's event to learn more about that population and their needs and their knowledge. So they're going to be able to compile all of that together in their comprehensive report. And then the qualitative data collection portion is really the piece that puts all of the literature and quantitative data in context. And so I think a couple of you have been asked for key informant interviews, and they're happy to do key informant interviews with any of the assembly members. So if you haven't been asked specifically, please reach out to myself or Sarah, and we can get that arranged. So they're conducting those key informant interviews with business folks, neighborhood folks, homeless people, a large swath of people. I think they've done about 30 so far. Their goal is 50. They are conducting surveys. They may do some focus group follow-up after our community conversation, and then the community conversations on December 11th from 6 to 9 at the library. That is going to be, I'll speak more about that at the end of this presentation, but you should have received an invitation to that. And it is an event that has a capacity limit, so if you want to participate, we'd ask that you please register so that you could participate with them. So in terms of quantitative data, here are some of the data sources, and I won't go through every single one of these with you, but I wanted to make sure that you had that understanding of this is some of the data that will be coming to you. We're looking, obviously OSMAP has been very helpful in getting us Anchorage-based data, looking at DOC. Fire department's done a great job of collecting information on all the different types of substances that they come in contact with individuals who they're helping. Coalitions, community coalitions, United Way, 4A's, and some other data, and working with the university on data that they have available. So those are some of the quantitative data points. Qualitatively, what they're trying to understand is the impact that opioid crisis and substance misuse is having on the community of Anchorage. So that will include all, opioid substances, alcohol, any of the ways that those things are impacting us, understanding what the community-specific drivers are, what people's level of knowledge is. We agreed we would provide some initial findings, and so the level of knowledge and stigma associated with substance use has been pretty consistent so far in their data collection. Looking at this mitigating factors, gaps in current programming and funding, and what the greatest needs are. They will be doing basically a prioritization of what the greatest needs are and what can have the biggest impact and what can we actually do in quick order. The other thing to know is they're collecting this qualitative data. If there's something we're finding that we could start working on now, we are going to try to figure out how to do that as opposed to waiting until the plan is complete. And I think there is a lot of looking at the relationship between the municipality and the community regarding leadership and the effort around substance misuse, and what our role could be, and just getting general feedback. So that'll be what a lot of the qualitative data looks like. They're doing that, like I said, through the key informant interviews, surveys, focus groups, community conversations. We're still continuing down the road, so if there's things that you think that need to be done or looked at that you're not seeing here when you review these slides, let us know, and we want to be responsive to what you think would be useful as well. So the basic initial overview, obviously, I can just tell you from my own knowledge, alcohol-related deaths and opioid-related deaths we carry the volume of that in Anchorage. And that will be clear in our report. There is definitely a continued root stigma related to just addiction in general, that it's a choice, that it's not a disease, that actually impacts the brain. So that is very clear just from conversations, whether it's on homelessness or anything else, there's definitely a disconnect with understanding addiction, and so we'll be working on that right away. Crime has obviously, the increase in crime has brought attention to the opioid issue and other substance misuse issues in general, which means that it's a good time for us to be able to move forward on it. I think there's a need and a desire in the community to work on this issue, and that it's not just an opioid issue, it's not just an alcohol issue, it's not just a substance use issue. We have a generally polysubstance use issue in this city, and we continue to struggle with that. And so that'll be really clear in the data. And there's this one heat map that, we could do this with alcohol, and I think they'll have some of this information in their final report. It's just a heat map that shows that no area is protected in the community from the impacts of substance use. This one in particular you may have seen before from the fire department. It's a heat map of Narcan administrations for the first through, this year through October. And it just shows you like it's not just one part of town there. This is happening all over Anchorage. And so the last thing we wanted to let you know and make sure that you have a little bit more information about is the community cafe style conversation that we will have on December 11th. Ann Hillman is volunteering to be a lead facilitator as a community member. We'll have food, on-site childcare, and we're asking folks to register if you're going to attend. And we're really looking forward to it. They've been working hard on this. Our timeline for the project in general is we get through the community conversation, and then January through February they'll be finalizing all their key informant interviews. They will be finalizing their data and the assessment, and then they will be we'll be forming a substance misuse policy committee to basically make some determinations about what we should move forward. And then in March, the community assessment would be completed in a draft form, which we could bring to you at that time. And then we hope to finalize the assessment in April and work with the policy committee to finalize proposed recommendations and move forward. Our May 1st is our final date for completing the project, as our urban fellow will be done with her project right in the middle of May. I think middle of May. So that's our hard deadline, and she's very focused on having this completed, and that is our timeline for this project.
Mr. Dunbar?
Thank you, Chairman. I apologize if you already hit on this and I missed it, but in putting together this project, I'm curious the role, I know you're getting data from a lot of different groups. I'm wondering the role that sort of a frontline healthcare providers play. I'm thinking particularly about people, nurses, physician's assistants, perhaps ER doctors, but more the people who deal face-to-face with the drug-seeking behavior, and how that's going to be built into that, and what can we do, if anything, when we have, sort of very obvious drug-seeking behavior within our healthcare providers.
Yeah, and I think that the state is way ahead of us on that. Now, I know that Sarah will be doing key informant interviews and learning about how those individuals that are in those roles, how they experience that. But I'm going to let Andy discuss with you guys what they've been doing around a lot of things around prescribing and with providers. I know for the last few years, just from a peripheral from my other jobs that I was doing, that there's been a lot of work with physicians and the community. So I'll let them answer the question.
Yeah, I could add to that. In OSMAP, we've actually hired a nurse practitioner who will be doing what we call academic detailing. I hate to compare it kind of like to how the drug sales reps were, but there's a lot. I mean, it's pretty amazing when you work in the ER environments or the doctor environments, how little they know about pain management. And so really getting them up to speed. We partnered with Fairbanks Memorial Hospital. We put some documents already out about treating pain, the conversations you should have. This academic detailing will also, we're looking at bringing in, we're talking right now, Stanford uses a model where they actually bring in individuals in recovery who have that experience in the drug-seeking behavior, and you act through to get the physician or nurse more comfortable with how they should actually handle that situation. I mean, obviously, the last thing we want to do is continue to feed the habit, but at the same time, kick the person out on the street. And so we've been doing a lot of education. We've launched platforms called Project Echo. Project Echo is a platform that allows providers in the behavioral substance use disorder world, but also non-substance use disorder world, who can come together, and this is from across the state. It's hosted by UAA, ANTHC, and Providence. And so when we have scenarios that are very complex, providers can get on, and it's kind of a peer mentoring or peer environment, and that seems to be helping quite a bit. And then we're continuing to push out continuing education courses for providers, and so we have dedicated staff. I'd like to say a whole bunch of people. Right now, I'd say it's two. One who's a public provider education specialist, and the other who's a nurse practitioner, and we'll continue to expand those roles in partnership with our communities.
There's also a lot of funding opportunities coming out that will spill up MAT waivers, so people can get training to get waivered, and ideally following models like Rhode Island's, where you're getting ER physicians data waivers so that they can immediately provide access to treatment
And the biggest concern with that, so yeah, a provider then could provide, various forms of substance, medication-assisted treatment. But what we've heard from providers across the state is, great, I've gotten this thing. Now, how do I actually use it? You get this certification or whatever it looks like, right? It's now, how do I actually implement this? And the fear that we want to make sure is that these providers are providing some form of MAT, that they are linking up and have that warm handoff, because just providing MAT without the behavioral health, the counseling, the psychosocial services, whatever, behind the scenes, we're really then setting our system up for failure. So we're going to be, as we launch further DEA data waiver training, we're really starting to explore how do we expand that more so our providers are comfortable, they understand the warm handoff, they understand the capabilities, limited probably within our communities, but at least what they could be, linking up with. So our peers, our SUD providers, the whole 9 yards. We still have a lot of work to do there, but I think we're moving the needle forward quite a bit. So
We've paired up with Sarah Spencer, Dr. Sarah Spencer. She works in Adultech. She's an MAT expert, and she is identified as the state targeted response at a federal level for technical assistance for Alaska. So we paired up with her and our state opioid treatment authority, Katie Chapman, to really address the barriers that providers have to utilizing their waivers. So like Andy said, a lot of folks we have about 321 people waivered right now in Alaska, but are they actually utilizing that training right now? Are they actually prescribing Suboxone and such? And that's the thing that we want to address. How do we connect people to care coordination and get them more confident in prescribing? So.
Can I ask a follow-up, Madam Chair? So this might be a little bit off topic, but I'm just curious because I've become friends with a number of folks that are working frontline ICUs and things like that. And they say, you've got a person there who is experiencing a variety of health issues because they are an opioid addict, and while they're in the hospital, they say, my pain is a 10. Pain is a 10. So what can they do other than push the drugs? I mean, what can they do other than give them what they're asking for?
Yeah, I can actually, following this meeting, Suzanne, I can actually send you the chronic pain discussion tool card that we have for patients and for provider to adult patient, provider to youth. I'll make sure to send that to you. That's one tool. The question is, when we say, use alternative forms of pain management, if it's acupuncture, whatever it is, the hard part is we need to continue to work with our insurance agent, companies to actually support those modalities or those forms, and that's one of the barriers that we continue to hear is, this is great, but
if your patients are not interested in that, they're
exactly.
like, why, I'm here, my pain is a 10, give me whatever it is, fentanyl, or I don't know what the actual thing would be, but give me what can they do other than give them the drugs that they're asking for?
So we also have a lot of motivational interviewing training operated out of DBH, out of behavioral health. And so that's being scaled up as well with some of this funding coming in along with their effort.
And you're kind of asking what would be some potential other substances or other drugs,
or even, or what are the consequences for them if they just refuse refuse.
Yeah, I mean, if they refuse to take it, that is a consequence that makes us extremely nervous, because what does that lead to potentially? Well, if I'm not going to get what I need here, where are they going to go? They usually end up, a lot of times they'll go to the street to get the potential substance. That is not something we want, but that is becoming, unfortunately, when you have a response and you've got an enforcement and a treatment aspect of it, the pendulum has swung probably a little bit more this way. We are trying to bring it back. That is something we're working on. We're actually in the midst of that as we speak right now today, working on a lot of those big issues. So,
Yeah, and one of the guidelines out of the CDC prescribing guidelines is to not just cut somebody off, but to taper them off. And so part of our provider education efforts is along the lines of really educating them about those, about the Washington guidelines, which Alaska adopted. That's based on the CDC guidelines. So it's, I think we have the impression that a doctor should just cut people off, and that is extremely troublesome. So we want to make sure that they know to taper people off, and that can help somebody who's kind of really desiring that substance. So.
Thank you, Mr. Dunbar. Thank you, Ms.
Yeah, thank
Pineda,
you.
for the presentation.
I have more
do you
questions. Yeah,
okay.
a couple of things.
Mr. Hassett?
Yeah, for you folks, I was hoping that we would get, maybe set up as a regular process, a briefing on your quarterly updates on the opioid emergency crisis. So that's for you guys. I have one for Natasha.
They've got
I can
that
address that
next.
real quick. Here's one thing
Yeah.
I'd love to highlight.
Because they're going to, I think, do a full presentation on data.
Yeah.
Oh,
Yeah.
Yeah, yeah.
I-
They've
What
got a
we
whole
can
thing.
also do is I'm going to
Okay.
talk with, I think the next step is, we do these monthly, these are situational reports. It highlights what we at the state are doing, our actions. And the governor, he's not one that says, this is what we're going to be doing, but what we have been doing or currently doing. We actually pull syndromic surveillance that highlights the hospitalizations within the state and the overdose deaths. And then we actually will pull some data from the Department of Administration, which Natasha's got probably way more, but Alaska Care number. So I think these are things I'd like to start,
Yeah.
Natasha gets it now finally. This partnership's starting to build a lot more, which is exciting, but I don't see why this can't be open source information. So one of the things is I'm going to work to put this on our website, but also make sure you guys get your eyes on this, because this is the actions that are taking place in your community, which you probably definitely would like to know about.
And structurally, like when we're in an open incident, so the state's EOC, they do send me when they produce their, is it called an incident action?
Yep. We have two things, an incident action plan that...
And that comes out to me, and then it's my responsibility as the director of the health department to distribute that within the municipality to the appropriate parties. And so we're just learning what that means and in this particular case. Now with this one, it's a lot more straightforward because we know it would be distributed to me, and we can distribute it to you, or I can pull it off the website and make sure you're getting it when they come out. All of that stuff we can do.
So there's like a quarterly one that comes out that's pretty omnibus, right?
Yeah, we have a quarterly one that comes out. We also have a yearly one that the legislature requires us to. This was our first year, and we thought it was, to be honest, more around Project Hope, because not SB 91, the criminal justice reform, but SB 91, the extension of the epidemic disaster. So it's going to be much more comprehensive next year. These monthly ones are pretty well, I would say.
Yeah,
the nice thing
good.
is it's chronological, which is nice. Under my incident command structure, I killed the incident action plan model because it became so confusing to people who are not used to ICS. They're going, you got a situation report and you got an IEP, what the heck is this? And so we just streamlined it to where we all know what our roles are. We know what our structure is. We still have every other, like this Friday, we're going to have an internal meeting, and then once a month at the cabinet level. And these are what we produce, which seems to work perfect for us. So, yep, these are pretty comprehensive too. But we keep it small enough to where you're not going to fall asleep and this is going to fall on your face.
And they send them to me, and if I have I can distribute them to them if I have the approval to do so. And so I would do that.
Hopeful, as this process goes on, though, that maybe quarterly or at least twice a year, we get together and go over these reports so that it comes straight from you, not just through this.
And they've invited us. We've attended a few of the cabinet meetings and participate in those. And I participated prior to my current role. And so, we will figure out what the right level of my participation in those is and keep you updated in the interim.
Thank you.
Definitely.
And then just back to this document, what are the credentials of the people conducting this community assessment?
Oh,
Because I understand Sarah, I did my review, it's great.
Yeah.
She's
Sarah did. I can't tell you. I didn't bring her bio, but I can tell you that she conducted key informant interviews in the country of Georgia for multiple years as the Peace Corps, and I can't remember exactly what her degree is, but she's got extensive experience doing certainly key informant interviews and literature review and pulling together that information. So she's worked with highly vulnerable populations, primarily in foreign countries.
And so what about this National Guard person? How do we go about getting a National Guard person? First off, credential-wise, what is it? And then there's a conversation around that should be had. So.
Yeah, I can tell you that we got him because primarily Andy and I sat down and discussed what our needs were. They're in an open emergency, a declared emergency, right? So
Yep.
that you guys, you could explain
So
better
it's
why
kinda
you could
like
deploy
EMIT.
it.
I realized the community of Anchorage was asking for help, so we deployed Elijah. Elijah is their civil operator. I can get you his credentials.
What does that mean?
Yeah, that's a good darn question. So you have in counter drug, you have intel operators. They work over with the Alaska State Troopers, DEA, FBI, and they're the ones gathering intelligence for the law enforcement footprint of it. And then you have the civil operators, and what a lot of times they do is they build community coalitions. They have extensive training in community assessments at a national level. But it's a very new role still, and they're defining that as we go. And I'll be honest, Alaska is pretty much defining this. Now, Elijah, we have a partnership with Alana and our staff at OSMAP. They're the ones who actually executed the statewide community cafe event. So that's why we felt Elijah was a great asset to put into the community. One, he lives in this community. Two, he's phenomenal at working, just, that connection and talking with people. And the uniform always helps a little bit. So these are not doctors. These are not SUD providers. But what the model we've taken is we collect the information, and then when we bring it back, it's kind of like the State Opioid Action Plan, is we bring the experts around with this information and say, guide us. And so we're not burdening these professionals who are the front lines providing the resources. The one thing I'll highlight that I'm going to jump a little bit is we are partnering right now with Anchorage. We realize that Anchorage is the only community in the state, one of, that has a local public health authority. So we're unique as anywhere in the country, but we see a value of trying to put some money into the department's money into the department to hopefully maybe they can fund a SUD prevention specialist. So we're working diligently to find that funding mechanism, and I'm feeling pretty darn good that we may have found it. So, and that just helps us because I'm a small office, and it's
Anchorage is the big city.
It's a big darn city.
So then this report is co-authored by the community and the state?
So Alana, what she's going to highlight on is we have a current draft of the State Opioid Action Plan. Now, just to give a little, that is going to go in front of the governor currently, and it's going to be a transition document for the governor-elect. But what we've talked about with Natasha is we don't want to hold on that document, and so we are going to work together through this process. It's a partnership, and then when this plan is done, we're going to compare the two and say, what do we need to put in the state, or how do we complement the two plans together? And so that'll be something.
It's coming from our department, so we're
Yeah.
providing oversight to Sarah and Elijah. We meet every week.
Right, so this is our report.
This is
Yeah.
our report.
We are just
partnering
supporting.
and supported by
Yeah.
the state.
I see it as a support mechanism. What do they need? It's like, do you need food support for it? Do you need
Right.
staffing? And that's the model change that we're trying to take, at least at my office in the state, is we work for you guys. You are the community. So
Okay. It's interesting. I have neighbors that are asking for National Guard support in the parks. And so at least the National Guard is doing something for the community when
Yeah,
they don't have the resource.
Yeah.
Right.
Along
We're
with
not
the
in a
resources.
declared emergency state right now, so those kinds of things all happen through a totally different mechanism. I can't draw on the National Guard anyways. I think that's a mayoral responsibility. But because the governor has already opened that door and we have access to National Guard and counter drug, we've been very lucky to take advantage of that.
And that's what our office does. You ask for an asset, and then I'll start looking for it, and we go from there. So
And pretty much since I started, we've been in contact pretty really regularly, looking at where are our gaps, what have we not carried the water on, and what can we push forward, and this is what we've pulled together.
Thank you, Mr. Constant. We have about 15 minutes left, which you can use to update us. I just wanted to check in real quick. Is there anyone in the audience who's planning to testify, to speak today? Did Mr. Haberly leave? Okay. Okay, Andy and Alana, it's all yours.
All right, sounds good. Let me get the lights
Yeah.
dim. All right, so I first want to bring your attention to the blue packets in front of you. You'll have on one side, you have all the statistics regarding not all the statistics, but a lot of statistics regarding the opioid epidemic. One kind of broad assessment came out in August regarding anything from just use to treatment to naloxone distribution. And so that's pretty comprehensive. Wanted to make sure you have that in your hands. The second document is a document that just came out. It's the 2007 Drug Overdose Mortality Report. And it highlights what's occurred in the last 5 years with the variety of substances. And then the third thing on that side is going to be just a few highlights per 6 months of what's occurred over the last 3 years. And then on the other side of the packet is our response and what we've done, as well as a one-pager regarding our office and just a couple materials you can take back to your office and hang up if you want. So starting off, go ahead. So we all know the opioid epidemic is devastating a lot of lives and has been for a long time. So it's the leading cause of accidental death in the U.S., exceeding deaths from automobile accidents. And in fact, CDC estimates that in 2017, drug overdoses killed 72,000 Americans. This death toll is higher than the peak yearly death totals from HIV, car crashes, and gun deaths. More than 6 out of 10 drug overdose deaths in 2016 involved opioids, involving opioid pain relievers and heroin, with more than 46 people dying per day from overdoses involving prescription opioids. And as you can see here, in 2016, drug overdoses likely killed more Americans than the entire wars in Vietnam and Iraq. In comparison, more than 58,200 U.S. troops died in the Vietnam War, and more than 4,500 have died so far in the Iraq War. So it's pretty ravishing. So what's happening? So what folks are doing, their tolerance is going up. They're also being cut off from prescription opioids. So oftentimes they'll resort to heroin and then even stronger doses than that of fentanyl. So approximately 3 out of 4 new heroin users report having misused prescription opioids in the past. And this has to do with easier access to heroin sometimes than prescription opioids because it doesn't require a prescription and it's actually cheaper on the street. And then you also have a higher risk of overdose from fentanyl use due to potency. Fentanyl is 100 times more powerful than morphine, and heroin 50 times more powerful than morphine. So this is why we saw last year an increase in overdose deaths because of the fentanyl. Again, just to highlight the fentanyl deaths, and overall in the U.S., there were 63,632 lethal drug overdoses reported in 2016. 29,406 were related to other synthetic opioids like fentanyl, and mostly all fentanyl.
Fentanyl is present in Anchorage, but the trends are sometimes slower coming up here, so I feel like we're starting to see more and more of an emergence, especially in these last couple of months.
So, focused on Alaska specific, we have a ton of data, but I'm just going to highlight a few things. This is for our youth respondents who fill out the YRBS survey. And as you can see, and just to highlight real quick, so for the correctional line, we just don't have data for 2013, 2015, and that's why it drops like that. But you can see that correctional facilities definitely have higher rates of people reporting ever using heroin, with it being 10% in 2011 and 22% in 2017. Overall, it's hovered around 3% in general, and as you can see, alternative schools and correctional schools tend to be more vulnerable to.
What age do you call a youth?
I think it's 14 to 18 years old. And you can also go online and gather data according to youth, or according to age and ethnicity and all that. And then looking at youth misuse of prescriptions in 2017, we changed the question up for 2017, so I just have this question. And it's people reporting that they've taken a prescription pain medicine without a doctor's prescription or differently than how a doctor told them to use it one or more times during life. And then as you can see, 15.5% overall indicated that they've done that, and then it's much higher for correctional and alternative facilities. Hospitalizations. So this is in your health impacts, or the assessment that came out in August. And so for emergency departments, we've got in 2016, 43.5 per 100,000 ended up in the ED because of opioids. In 2017, it was 52.9, a 22% increase. And then in 2016, for inpatient hospitalizations, 28.5, and and then 26 for 2017. So overdoses. So at the top you'll just see a line for all opioids. What's occurred is that heroin's actually gone down, so that's awesome. Fentanyl, though, went up for 2017, and that's why fentanyl is extremely alarming because it is so potent, and most people don't even know they're taking it because it's laced with so many different drugs. The epidemic doesn't discriminate. I just wanted to highlight a couple things. Between 2016 and 2017, the highest opioid-related hospitalization rate, excluding heroin, was among people over 65 and among females. For heroin-related, it was between the ages of 25 and 34 in males. For overdose death rate, it was 35 to 44 years old and 25 to 34 years old for heroin-related overdose.
Switch to the state or federal numbers.
Oh, it's a state. So it is alarming that over 65 has the highest rate of hospitalizations, and also how do we really reach our people between the ages of 25 and 50? Those are the people that are suffering a lot from the overdose deaths. So as it's already been indicated, polysubstance use is a huge issue. In March 2018, NIDA reported that more than 30% of overdose deaths involved both opioids and benzos across the nation. And so that is really important to note. And also, you can see that people who are addicted to opioid painkillers are 40 times more likely to be addicted to heroin.
And I mean, yeah, we call this the opioid response, this is the polysubstance response. My biggest concern right now is methamphetamine. I mean, it has come into this state at such a mass surge. It's alarming. And everywhere I go in the country right now, that is the discussion. Minus on the East Coast, we're seeing a resurgence of cocaine coming back. So that'll probably, if that even makes its way back up here, another year and a half. But methamphetamine's a big problem.
And that is in part because people who are taking opioids, it's a downer, and so when they take a stimulant, and they can function a little bit better. So I haven't seen studies really looking at this, but I have hypothesized that the reason why people are, why their meth is going up is because the opioids are going up. So people are trying to function, they just want to function every day, and sometimes you do that between a stimulant and a downer. So,
Question on that.
Yeah.
An anecdotal response I've heard has been, it's because access to prescription opioids has been closed off, and we've clamped down on heroin, so now people are going back to meth and cocaine because that's available.
Yeah.
But it sounds like
Meth is readily available. It's way pure. It's not as homegrown like it used to be back in the days. It comes all mostly directly from the southern borders.
Mm-hmm.
So yeah, it's definitely much more readily available. There's also, the other fear that we have is a lot of these substances are being cut with fentanyl now, and so you don't really know what you're taking anymore.
Mr. Dunbar?
So, thank you, Madam Chair. I'm looking at this. This is all 2013 to 2017 numbers, and do some of these overlap, or is this?
Yeah, so this was a chart. So this is in your 2017 drug overdose mortality report, and so what we wanted to show is how many overdose deaths had two or more substances in it. So you can see that for the 5 years, almost 17% of the overdose deaths had at least opioid analgesics or pain relievers and sedatives, which mostly were benzodiazepines, which, like I indicated just a minute ago, that is also happening nationally, where because benzos together with opioids suppress breathing and might increase the likelihood of overdose death. And yeah.
I'm sorry to follow up. So I'm trying to think how I translate this and this particular to community council, for example. I'm trying to show the scale between this and, you said nationally it kills more people than car accidents, for example. But can you give me an approximate number? If someone was asking me, how many Alaskans die every year from opioid overdoses?
We can, so if you'd like.
What would that, I understand there's some subtlety, like, this is mixed with that or whatever, but in general, what's the number you use when someone say?
So let me, if you're okay with it, sir, I'll send you some talking points based off 2018 data. So when you go to a community cafe or community council, this is great for maybe the healthcare provider world, but the community looking at this is going to go, what? So we've definitely started formulating.
What was this? What was it? 38 homicides in Anchorage last year. Was what we end up with?
There's 108 overdose deaths from opioids.
In Anchorage.
And are you guys counting alcohol? Do you have alcohol as well? Because that's also still high. So last year, like 191 people overdosed or died from alcohol-related causes in the state. A lion's share of those were in Anchorage.
Yeah.
And I think last year is somewhere in the 90s for opioid-related deaths. So I think
Opioid overdoses was 100 last year. Drug overdoses as a whole, which is all categories, is 141. Now this year, and Alana will highlight on that, we're at this year, and we have a little bit of a lag. We're at opioid overdoses 100 last year. This year, 41. So last year was a bad year, but I think it's because we started the response, we started getting out in the community, everybody's coming together. And and then obviously we had a skyrocket of fentanyl. So we went from 5 fentanyl deaths in 2016 to 28, but this year we're at 3. So the trends are looking good. Fingers crossed, though. I mean, data is lags behind a little bit, but we have some stuff that we've translated this into much easier verbiage for the community.
What we're looking at the city is to make sure that when we're putting together that information that we're setting alcohol next to it as well, because that has remained constant. It is constant and consistently impacting disproportionately in Alaska, and I'm sure that's true for Anchorage. I haven't gotten the chance, we haven't broken it down yet, but I think when we're talking to the community, we want to make sure we're looking at the whole problem, not just opioids or meth, but add it all together because we think it's a complete problem.
And on page 3 of your 2017 report, we have that alcohol was involved in 1/4 of drug overdose deaths from 2013 to 2017, and that does not include acute alcohol poisonings. So we definitely want to make sure that people know, again, when you combine a couple or more substances, you might have might be more likely to overdose from the suppression of breathing and all the physiological effects that happen. Okay. So just to highlight real quick that there was a huge increase in meth, as we've talked about. There were age-adjusted rates for overdose death from meth increased 211% between 2015 and 2017. So when we hear people say meth is the issue, they're not kidding. It's a big issue. And combining opioids with meth can also cause heart failure and other physiological effects that meth kills slowly. So what are we doing about it? So we've got the State Opioid Action Plan that Andy indicated. August 13th and August 14th, 93 Alaskans across 8 advisory teams came together at the Sheridan Hotel. They represented over 60 different professions across state of Alaska agencies, federal government agencies, and community-based agencies, and informed us what the plan should be. So this plan that's coming out is based on the voices of Alaskans, because we know that it takes cross-sectoral collaboration. All of these entities were involved in the statewide opioid action planning process, including most of these departments from the whole state of Alaska.
Oh, it's an all hands on approach.
It's an all hands, including these community coalitions. So we worked with these community coalitions across the state in order to develop the community cafes. The community cafes informed our statewide opioid action advisory team. So what we did was we collected all this information on the big Post-it notes, and then we gathered it all together and we gave it to the teams so that they could read through it and really understand what Alaskans wanted. We went to 11 communities and conducted 9 cafes in these communities to collect this information, such as Ketchikan, where there were 86 people across all different disciplines. We're also reducing stigma and changing social norms. We've got our new suicide prevention plan. We're building recovery story series. Teachers have access to an opioids and opioids epidemic 101 teachers module so they can educate their students. Public health nurses are instrumental across the state in educating people about social determinants of health as well as substance misuse. And then we've got our ACEs data that we always rely on.
So Alana, we were going to not say the stakes. We were waiting for the governor to announce it, but the governor just announced that our 1115 waiver demonstration project was approved today, and that's big news. I mean, that's going to increase community-based services, MAT services, early screening, and increase treatment beds. So that's a big deal. So we just found, I guess, that out this morning is what it sounds like. So that's good news for Alaska. We're 18th in the country to receive this waiver, demonstration waiver. So
Yeah.
Probably, I think maybe next time, I'd love to get somebody who come in from behavioral, Katie Chapman and maybe their group to really talk about the details of it, because it is a pretty complex concept, so I'd like them to come in, or we could at least maybe, Natasha, give you we have a one-pager that we could give to the assembly, so definitely.
And the other thing we're doing too is we're collaborating with UAA, Alaska Training Cooperative, to do public safety, mental health, first aid, train the trainers for 30 different individuals across the state for public safety entities. We're reducing the risk of misuse and addiction. We've got our distribution of medication disposal bags, like Andy talked about, our provider education. We have 6,580 prescribers registered, which is a huge increase. I don't know the exact amount from just a couple of years ago. And then we also just received high-intensity drug trafficking area funding, $5 million to improve trafficking oversight. So this is really important. We also are looking into potentially doing a provider hotline, doing a provider app, and an Alaska Addiction Medicine Fellowship. We also are trying to reduce the harm of drug use. So we've got 92 overdose response programs across the state. We've already distributed 16,000 overdose kits, saved 200 lives. And if you know of anyone who would like to become an overdose response program, that is the email address to use. And as Andy said, 1115 is super important to improving treatment efforts. The other initiatives that are occurring is we're scaling up MAT-trained providers. We already have 321. We have over 300 residential treatment beds. We have the $12 million substance use disorder expansion that we're delivering through grants. And then we also have DOCs behind the walls, MAT using ViVitrol, and DOC is doing a ton of work to improve treatment access.
And we actually got DOC to agree, all superintendents across the state, to want to provide all MAT services, no more of this tapering approach. The problem there's always a problem, I hate to say that, but right now we're identifying at the federal level who will provide the funding for us. I assumed SAMHSA would support something like that. I was wrong. And so we're working at the leadership level, but it sounds like the Bureau of Justice Assistance is very interested in this project. So we've got the energy, we've got the motivation behind the walls, and so it's great that we're providing ViVitrol. I'd like to just see the services provided much longer than a month before release, because I do feel like we're going to continue to increase our recidivism rate with that model. But it is something we're moving in the right direction.
And if you'd like to see what the availability for treatment is, on DVH's website, you can go to that and they'll show you in real time how many beds are available and what the wait list is like for each facility. And then we're also building a community of recovery. So we've got the Opioid Crisis Intervention and Community Involvement Project out of the Department of Labor, and that increases employment opportunities and outcomes for those impacted by opioid overdose. We have a paracertification process being worked on currently at the Division of Behavioral Health. We have our support and employment program, and then DVH is funding recovery housing efforts that are in the works right now, like sober living homes. So just to give a bit of hope, we saw about a 50% decrease in the number of overdose deaths in the first 6 months of 2018 as compared to 2016. So we're working hard. We're trying to combat this crisis. Takes time, but it's going to happen.
I never liked using a metric of overdose deaths, because tomorrow that number could change. But it's encouraging to see the current trends. I'm hoping through naloxone, but just because we're providing naloxone doesn't mean that they're getting the treatment and the help they need. But at least it means one last Alaskan's losing their life, and so it gives us some time to continue to try to build this model. So, yeah.
Thank you, Andy and Alana. We are out of time, but
Just
any
a quick
questions?
comment.
Mr. Hostet?
Thank you, Madam Chair. When you speak about MAT, I would caution to not say give them their MAT and send them on the way. It's you give them their M and send them on the way, right? So if we're careful in how we speak about these things, we might actually start to feed the message into the head of the providers that we're providing an MAT program medication that must be assisting treatment. That's kind of the missing piece that tends to be reiterated over and over again. We call it MAT, give them a pill, send them on their way, say, good luck. That's just the medication part.
And I'm glad you bring that up, because the fear I've heard is the stigma with use is still there. There's a bigger stigma with treatment at this point, is what I feel. There's that abstinence space versus non-abstinence space, and I think we all agree that we have to have all pathways to recovery available. And so we saw, I hate to say this was one of the big issues we saw at the Anchorage Task Force for quite some time. But I think that's been curbed, and those discussions are starting to change. But
and the way I see that, maybe we're kind of connecting on this. I hear Housing First providers say treatment first people are. You know, they kind of look down, and to me, it's there's got to be an intervention across the board that works for the individual, not what works for the provider or the community.
Exactly. We meet the individual where they're at, I really believe, yeah.
And
I've been
provide
reading,
options.
yeah, there's been some, it seems like there's emerging science and understanding coming out that people who have been using some of these heavy-duty chemicals, they have a permanent change that will require medical-assisted treatment, possibly a perpetuity, like you would see for somebody with diabetes or others. And if we're so far behind as a society in Anchorage that we actually believe it's a choice, we've got a long way to go on working on perception, and that might be something that our department can help out and work on with people, is get us to a better level of readiness, because people are permanently damaged, and we have to treat them like they are. Yeah, it's different. Like, we're moving into a new world where the alcohol model of abstinence doesn't apply to these substances, and we're not having that conversation yet, like at a broader level.
I think we found it applies even with just alcohol if you narrow the population to a certain subset of the permanent chronic inebriated who has been out there using for 30 years.
There's
They're not coming back.
They need something different.
You're going to help them come to a point, and you're going to assist them.
We are coming out with a public education campaign about how addiction is a brain disease, trying to address this stigma and make sure people know that it's actually a complete change of the brain. And so, how do we fix that?
Well, thank you to the three of you for your presentations and discussion. Are there any other comments or questions, or anyone in the audience who wanted to speak?
I'm Matt with 4-H. I just have some data I wanted to share with you guys. In June, we started collecting new information from our participants, which consisted of like what substances that they disclosed using and or disclosed. And their disclosed living status, so if they're have stable housing or homeless. And then, so that first page there is all the, starting from June until October. So we have done 2,222 new intakes. We expect that to reach at least like 4,000 within the first year. And then we have the 2 new questions that we've been asking, along with some of the demographic information. And then the syringes given and syringes returned. And then that second page there kind of highlights our HIV and Hep C testing, and then the same demographic information just from the FY18. So I just want to share that with everyone.
Thank you for providing this information.
This is great.
Wow.
I have a quick question for you.
Mr. Constant?
Thank you, Chair. So again, the number of returned syringes exceeds the number of given syringes. And I still see syringes littering the parks. I have a picture of 40 of them under a bridge that showed up yesterday.
Sure, yeah.
So what's the source of all of these needles?
So folks can buy them over the counter. So that can kind of be where that difference comes from. We don't make people count out like each syringe in front of us. They can bring in 300. So it's more of kind of a guesstimate. We have a good eye for that at this point, but still, somebody can bring in a big jug and say that there's this many. We're not going to count them out, so that can kind of be where that comes from as well. But we try and incentivize it. We have recently lifted our limit from 50 to 200, and so
This is good, right? I mean, we want more return than given out, right?
I just am trying to understand the dynamics of the access to the needles.
Yeah, and like I said, folks can go to a pharmacy typically and buy more at the counter as well. So.
Thank you, Mr. Constant. Thank you for providing this information. Any other questions or comments? Have a happy Thanksgiving. Thank you for coming. We are adjourned.